Morning. Good evening, Gopal. You are there?
Good morning, David. I was muted. I was sitting a little distance away. I'm back
good evening,
now.
Gopal.
Good morning. Good morning.
Good morning, sir.
Morning. Morning, Chetan. Please start.
Sir, is my screen visible and am I audible, sir?
Yeah.
Good morning, sir. I'll be talking about management of patellar instability. A brief anatomy. Patella is most prone to dislocation in 0 to 30 degrees of knee flexion. That is before the engagement of the patella within the femoral groove, where the MPFL actually functions as the primary restraint to lateral patellar subluxation. And in order to preserve the native biomechanics, the graft should be tightest in extension and isometric from 0 to 30 degrees of knee flexion. Classification of medial patellofemoral ligament injuries. It is broadly classified into femoral side, patellar side, and the intrasubstance. And in the patellar side, it is type P0, which is purely ligamentous, P1 with a bony avulsion fragment, and P2 involving the articular surface of the middle facet of the patella. The main treatment is conservative, especially in the first-time dislocators, except in the cases where the patient is having loose bodies. And managing conservatively will actually allow the effusion to resolve and recondition the vastus medalis obliquus. And there are various studies that has been reported to have a positive role in VMO reconditioning, which allows adequate return in range of motion and function without recurrence. And investigating to explore further numerical risk factors has been discussed in previous class is also essential, and MRI is the treatment of choice. Furthermore, patellar taping and stabilization can be used to moderate effect to decrease the patient's subjective feel of having instability. And unfortunately, in majority, it might fail, causing recurrent patellar apprehension, which actually indicates residual microinstability with subluxations. Coming to medial patellofemoral ligament reconstruction improper. The first thing is identification of the femoral attachment. Shottle actually described the radiological landmark, which is actually it is just anterior to the posterior cortex of the femur, tangential along the posterior cortex of the femur, and distal to the posterior condyle of the femur, around 2 mm distal to the posterior condyle of the femur, and above the most posterior point of the Blumen's X line. The drawback is it is actually Shottle's works very good in normal femoral anatomy, and if there is any anatomic variations such as trochlear dysplasia or congenital MPFL deficiency, it is little difficult to find out. And it had been reported that it had the low accuracy exceeding the actual critical threshold of 5 mm distance to maintain the anatomical MPFL insertion. Stephen et al. Described the other landmark where he divided the anteroposterior size of the femur into 100%, and the MPFL attachment is actually 40% from the posterior and 50% from the distal. However, few researchers still locate the femoral insertion by local anatomical markers of the middle femoral condyle, and it is the saddle between the adductor tubercle and the middle epicondyle. Now, coming to identification of patellar attachment, it is usually the junction of the proximal one-third and distal 2/3 of the longitudinal axis of patella. Uh, patellar double tunnel technique is the closest method to MPFL anatomical reconstruction. So many methods have been described. It is either bony tunnels or anchors, but the fixation strength of the patellar tunnel technique is actually matching to the native MPFL. Anatomic and non-anatomic MPFL reconstruction. Anterior malpositioning of the femoral tunnel can actually cause overloading of the middle patellofemoral cartilage, leading to cartilage damage, and excessive graft tension with knee flexion will actually stretch the graft, leading to its failure and cause redislocation. So this is the study by Tonat et al. In Kista, and they described that femoral tunnel that is too far proximal, which it can be correlated in this image, which is too far proximal, will actually cause graft laxity in extension and graft tension in flexion, which is actually characterized by anterior knee pain and loss of flexion activity. In contrary, if the femoral tunnel is too more distal, it may lead to graft tension in an extension and laxity in flexion, which would manifest as an extension lag. Coming to MPFL isometry, isometric placement of MPFL is that full range of motion can be achieved without any evidence of ligament elongation. And the principle of reconstruction is to obtain isometric ligament at 0 to 30 degrees of knee flexion. But the MPFL graft should be tense during knee extension and lax during the knee flexion, as described previously. And it has been so many anatomical studies have been conducted, and it has been noted that change in length of at least 5 mm will be there from full extension to deep knee flexion, which would prevent the knee dislocation. And it has been concluded that MPFL anisometry in the early stage of knee flexion is actually to prevent the lateral patellar dislocation. And after 30 degrees, it is actually isometric because MPFL is no longer important in maintaining the stability, and it is taken over by the lateral femoral condyle. Parker in 2008 compared kinematics of patellofemoral joint between MPFL isometric reconstruction and anatomical reconstruction in the cadaveric models, and they concluded that isometric reconstruction could not actually restore the kinematics of the normal patellofemoral joint, and whereas the anatomical reconstruction could restore normal patellar tracking at 0 to 28 degrees of knee flexion. The graft tension, coming to graft tension, so few researchers suggested that 10 newtons of graft tension is actually needed to restore the PFJ mechanics. But there are other school of thought where it is 10 and above 10 is actually more and causes increased contact pressure and middle patellar tilt. So usually the contralateral side is taken as reference. And in bilateral cases, the method of Coe and Stewart can be applied. They described the postoperative MPFL graft tension should actually allow lateral displacement of the patella with 1 centimeter in knee extension, or approximately 2 patellar quadrants of the lateral translation with a rigid stop. Knee flexion angle, it is very controversial and there is no final conclusion. Few researchers said it has to be tightened in full extensions, and a few said it is in 20 degrees of flexion, 30 degrees of flexion, 30 to 45 and 45 to 60. Usually, the routinely followed knee flexion angle is around 30 degrees. Outcomes of MPFL reconstruction. Post-operative patellar tilt. Once the MPFL is reconstructed, and it was noted that there is significantly reduction in CD ratio, especially in the patient which had in whom the CD ratio was 1.2 preoperatively, and it has been clearly referenced in the study by Hemstra et al., which was published in March 2020. And Erickson, in a study of 90 patients, undergoing MPFL reconstruction, regardless of any bony pathology such as TTG distance or patellar height or trochlear depth, reported good clinical and functional outcomes at 2 years with 0 failures, and 88% of them returned to the sports. And this study by Liu et al. In 2018 confirms that isolated MPFL reconstruction is actually very substantial for patellar instability with trochlear dysplasia. And majority of the patient can actually could actually return to the sports at 1 year of age. So bony pathologies, regardless of the bony pathologies, isolated MPFL can actually give a good result. Coming to the femoral version, it has been assessed that increased femoral version has been associated with worse Kujala and Lissom and IKDC scores. And when the MPFL reconstruction is associated with derotational distal femoral osteotomy, the scores actually improved. When additional soft tissues is been associated with MPFL reconstruction, such as lateral retinacle release, which was famous in the olden days. This is a study in 2018 by Maletre in Kista, and they actually declared that there is no significant difference in mean IKDC scores or patellar tilt at 2 years post-op between the groups with isolated reconstruction and retinacular release. Predictors of outcomes, it has been found that bilateral symptoms or older age at first dislocation and the femoral tunnel malposition were significant predictors of lower post-op scores. Another study showed malposition of femoral tunnel and residual patellar tilt were associated with worst outcomes. And the common factor in all these 3 studies are the femoral tunnel malposition. Graft, it is various grafts have been used, and all have been given the same result without any difference. And fixation in the graft, it is either bony fixation at the femur or soft tissue fixation. Bony fixation is the interference screw. Soft tissue fixation is looping the graft around the adductor magnus, and no significant difference in the graft fixation. And this is the study by our institute in 2014, where MPFL reconstruction is used using restless graft with endo button on the patellar side and bioabsorbable interference screw on the femoral side, followed up for more than 20 years of 30 cases. And none of them actually had any significant, any dislocation, except for 3 patients who had apprehension. And it has been shown to have very satisfactory results. So the initial indications for isolated MPFL reconstructions were only these, which is normal TTTG, which is less than 20, or de jure type A trochlea, and CD measurement of less than 1.2. And this study in 2021 actually showed that it provided sufficient evidence that TTG distance on its own does not dictate the treatment algorithm. And it had 2 groups of treatments, one with TTG less than 20 and more than 20, and both of them performed with good functional outcomes at 1 and 5 years of follow-up. MPFL reconstruction in skeletally mature patients. This is a study by Levy et al. In 2020. This the first image actually demonstrates the lateral retinacular lengthening, and this is the femoral. I mean, this is the patellar tunnels which is been conducted, and they actually described, especially in the patients where the physis is not fused, it is distal to the physis, just superior to the Blumenschatz line, and it is posterior to the trochlea. So, and this has been actually referred to as Kitt's zone. So the trajectory of the K-wire is actually directed distally and anteriorly, taking in consideration that it is not itching towards the trochlea. So sequential CM images are taken both in AP and lateral, so that to make sure there is no breach in physis or trochlea. And it has been at the patellar side, it has been anchored with the suture anchors, and it has been shuttled between the layer 2 and 3 of the retinaculum and has been fixed to the femur. This is a study where it described the arthroscopic reconstruction of the MPFL in skeletally immature. The principle of this surgery was through the scope, the adductor magnus tendon is actually seen, and the graft is looped around. Here they used peroneus longus, partial thickness peroneus longus tendon, the anterior half, and it has been looped around the tendon, and it is taken over the anterior surface of the patella, and it has been tied to the patellar tunnels, and it is brought out near the middle patellar facet and stitched. So coming to middle patellotibial reconstruction, the systematic review till now suggests that the complication associated with exclusive reconstruction of the MPFL was around 26%, and among the 26%, persistent instability totaled around 12%. So the reconstruction of one of the secondary restrictor ligaments along with MPFL could actually decrease the stress on MPFL and could improve functional outcomes. And this forms the basis of the treatment using MPTL reconstruction. MPTL is actually a medial capsular reinforcement from the inferior aspect of the medial patellar edge, going medial on the tibia anterior to the MCL close to the articular rim. And it demonstrated the secondary pain restraint to lateral displacement. And MPTL reconstruction actually aims to medialize the middle third of the patella, reproducing the course of MPTL, and it can be shown in the picture. This is by Zeffini et al. So the patellar tendon is split, having the patellar attachment intact, and it has been fixed on the anterior middle aspect of the tibia, just anterior to the MPFL reconstruction. This is one other procedure by Henkel et al., where they used quadriceps tendon for MPFL reconstruction and the patellar tendon for MPTL reconstruction. And the principle is they turned down and used the quadriceps tendon for MPFL reconstruction and MPTL reconstruction for using the patellar tendon. This is the latest study which demonstrates use of both MPTL and MPFL reconstruction in February 2013 in JRS. And it is the indication is persistent patellar instability, subluxation in extension, and instability in deflection along with genu recurvatum. So they used suture anchors for MPTL reconstruction. And here the tunnel has been drilled from the middle aspect and the anterior aspect, and it is connected, and it has been shuttled. So there is, and for middle quadriceps tendon femoral reconstruction, the sling of the quadriceps tendon is formed, and they used allograft of tibialis anterior. And after the final reconstruction, it is the image is shown as in the picture. So the enthusiasm in MPTL reconstruction actually led that few researchers actually told, actually compared whether MPTL reconstruction alone would give substantial outcomes, but it has been proven beyond doubt that it does not provide sufficient restraint, which has been confirmed in the 2020 study. Finally, the systematic review for the combined MPTL and MPFL, 9 articles were included, and the qualities of articles were actually variable from low to high, and actual further randomized control studies are needed to understand its adequate indications and clinical outcomes. This is another procedure where the quadriceps turndown is performed. The medial slip of the quadriceps is taken off, and it has been channelized posterior to the VMO, and it is slung around the adductor magnus tendon and stitched onto itself. A brief note on distal realignment procedures. This is a 3-in-1 procedure where this is quite historical, and it is rarely performed now. This is the 3-in-1 procedure includes the lateral retinacular release and the medial patellar translation onto the anterior middle tibia, and medial retinacular reefing. So based on this, there was a study in 2021 by Pujik et al., where they declared that Sparnet soft tissue procedure had mid to long terms, which with moderate good functional outcomes and satisfaction. Here it is lateral retinacular release A, and the medial retinaculum is actually, the slip is taken off, and it has been wound around the quadriceps tendon, and the lateral quarter of the patellar tendon is been split and has been transferred posteriorly and has been attached to the proximal middle tibia and medial retinacular reefing. So this is modified Gramont procedure. This is the patellar tendon, and it has been separated from the posterior aspect until the tibial, leaving the distal most tibial tuberosity attachment of the patellar tendon. And it has been, this is with the traction where in the previous image, we can actually see this marking where it is lateral and high above. And after sufficient traction, the ideal placement of the sutures has been marked, and it has been stabilized onto the tibia. And post procedure, we can actually see this is the pre-op mark, and it is of the post-op, and this actually corrects both the TTDG distance and also restores the medial check green for stability in the first 30 degrees of flexion. This is soft tissue loop, where the tendon is it has been taken in between the middle retinacular sleeve. It is taken over the anterior surface of the patella, and it is turned around, and it has been taken back and stabilized. Brief note, row bolt weight and along with the middle patellar reconstruction, this is the lateral half of the patellar tendon. It has been transferred posterior to the medial slip of the patellar, intact patellar tendon, and has been rerouted to the pes anserinus on the anteromedial aspect of the tibia, and it is sutured. This is a huge retrospective study from almost around 35 years. This has been published in 2023. Single surgeon performed the row bolt weight, where he found very good results in around 202 knees, and concluded it is effective in treating recurrent patellar dislocation in both pediatric and adult population. However, in trochlear dysplasia, patellar alta, and lateralized tibial tubercle, reconstruction of the medial stabilizer is at best regretting the situation which failed initially. In cases addressing the distal alignment, it is better to go with either TTO or RG procedure. Take-home message. It has been demonstrated that isolated MPFL reconstruction results in decrease in patellar height postoperatively. However, some studies have shown that substantial patella alta or femoral anteversion preoperatively increases the risk of failure after reconstruction. And the failure of the reconstruction is actually more when femoral tunnel malposition is present. And there is actually no consensus of about the optimal graft type or femoral fixation strategies, with similar results reported with each technique. Combined reconstruction of MPTL and MPFL could be effective in restoring patellar stability. However, strong capacities are required. Promising results in the recent years suggest that not all patients with bony pathology require additional surgical correction beyond isolated MPFL reconstruction. Thank you, sir.
Dr. Santosh is there? We'll have the discussion toward the end of all three talks, I think. Santosh, you're not there. Dr. Santosh, not there? I think maybe his signal is not there. So go on to the next one then. Habitual dislocation of the patella and persistent dislocation patella is covered elsewhere, Chiran?
Sir, previously covered, sir.
Oh, okay. Okay, what's the next talk?
Praveen is starting, sir.
Am I audible now?
Yeah, now you are. Now you are.
Okay. I got a call from the ward, so I got disconnected. So anyway, we'll have the discussion at the end also. So we'll go on with the talks.
Morning, sir. Am I audible, sir?
Yeah, Praveen, please go on.
Yes, so, morning, Aaron. I'll be speaking about assessment of rotational deformities and correction, particularly concerned with the lower limb. So, as we know, rotational deformity is primarily deformity occurring most commonly along the axial axis of the limb, or rarely can also have minor along the longitudinal axis of the limb. So it changes the orientation of joint on loading the joint, and hence leads to unwarranted biomechanical changes within each joint. Most of the rotational deformities are pretty subtle and hence have to be particularly looked for and have to be correlated clinically as well as radiologically to assess the degree of deformity. So the most common etiology is traumatic and congenital. Traumatic, as you know, is following a direct impact injury to the bone and the resulting malunion. However, more commonly occurring condition is either due to congenital reasons or developmental reasons. This again can stem from different causes. Primarily a deformity within the bone, or also due to neuromuscular disorders which alter the morphology of the bone with growth, and also soft tissue contractures altering the bone, and also other metabolic causes affecting bone growth. What are the causes that finally results in either an in-towing or out-towing? So with respect to in-towing it, the most common cause which can lead to it is the deformity either within just localized to the foot, like metatarsus adductus, or into the tibia with the internal tibial torsion. And with respect to the femur, an increased femoral anteversion as the patient tries to walk results in in-towing of the gait. And the same, the vice versa results in out-towing it. That is an excessive femoral retroversion or a decreased anteversion, and the external tibial torsion. This is an out-towing of the gait. Just quickly about the natural history of rotational changes happening in the lower limb. So at 5 months of intrauterine gestation, there is internal tibial torsion of 20 degrees, which corrects and presents to up to 2 to 4 degrees of internal tibial torsion at birth. And however, at birth, there is a femoral anteversion of up to 40 degrees. However, both these deformities progressively change with age, which can be seen up to 8 to 10 years of age. So at 10 years of age, usually there is a resulting external tibial torsion of 15 to 20 degrees, and then there's an external rotation of up to 20 to 25 degrees from the anteversion of the femur from birth, so resulting in ultimate anteversion of 15 to 20 degrees in the femur. Point to note is that tibial torsion usually adapts well with growth. So tibial torsion, even if present, usually adapts well over period and rarely becomes symptomatic. However, if there is excessive femoral anteversion present during birth, it usually invariably results in a deformity. So how do you go about evaluating the cases? The first thing is the history. Again, history pertinent to all the possible etiological factors we are worried about. So birth history, again, any symptoms or any deformities of the feet at birth, any prematurity or any internal IUG possibly causing restricted growth. And again, a developmental milestones history to look for any possible neuromuscular causes for deformity. And family history of most musculoskeletal disorders which can result in rotation deformities, probably like vitamin D rickets, mucopolysaccharidosis, or any epiphyseal dysplasias or achondroplasias. And also, we have to quantify the amount of functional impairment of the patient because of the deformity, since that takes the precedence in deciding the treatment. Okay, so moving on to the examination. So first, as discussed, the general examination should be done to look for any feature sized of other syndromic conditions which can probably lead to suspicion of deformities in multiple limbs. So we start by evaluating the stature, the posture, and also any signs of limb or spine asymmetry. With respect to the lower limb, these are the 4 indices we should evaluate for. That is the femoral rotation or version, the tibial rotation or torsion, and the foot progression angle, and any localized deformity in the foot. So how do you go about measuring the femoral anterotion? As we know, is the Craig's test, which can be done either supine or prone, but more commonly prone is preferred, since it mimics the walking position of the limb, and also pelvis stabilized better, and the angle can be measured better with the goniometer. So it is done with the hip and extension, knee flexion 90 degrees, and knee the leg is rotated internally extended. I look for position of the GT, hence which gives a measure of the version of the hip. So a person with increased internal rotation is increased internal rotation will have increased anteversion. The decreased internal rotation can be lead to decreased anteversion or retroversion or any other dysplasia in the femoral acetabular joint. Another point to note is that the amount of anteversion need not always correlate to the amount of version at the hip. So for example, so in this case, as in the first image, you can see the normal tibia, which is a normal alignment with the knee. So as you can see from the neutral, the deviation of the tibia is a measure of the anteversion happening at the hip. However, there is a deformity at the tibia distal to the knee joint, which can lead to misinterpretation that there is increased anteversion and increased anteversion of 75 degrees and decreased retroversion of only 15 degrees. However, which is not the case. So how do you avoid this discrepancy? We go measure the anteversion using the 0 point. So the 0 point is nothing but the point where the patellar is in line with the femoral contacts, both are in line with the horizontal. From this position, the degree of movement happening at the limb is measured using goniometer on the tibia. Other indicators of femoral anteversion is W sitting seen in children, basically due to increased internal rotation, winking patella sign. So this is a W sitting seen in children, and the winking patella sign is nothing but when the patient, so this is the alignment of the patient when the patient is standing with both patella facing forward. However, when the patient tries to stand, keep both the legs straight, you can see the patellas squint inward, tilt inward, giving to a winking patella sort of appearance. And the other thing is the egg beater running. So egg beater running is nothing but when if a patient with the internal tibial, increased anteversion as they move forward, because of the increased version, they take their leg goes through a circumflexury course instead of a straight line as normally expected. So their legs take this is the path they take as the patient tries to run. And other measures for describe measuring anteversion is the position of the GT with respect to transverse femoral axis, transverse femoral contacts, but it's clinically difficult to measure and not totally recommended. So moving on to tibial rotation, it is measured using a thigh foot axis. So which is basically a sum of deformity within the leg distal to the knee, sum of both the tibial and hindfoot rotation. So as you know, it's done with the knee in patient prone, knee at 90 degrees, and ankle neutral, and the ankle between the foot and thigh is measured. So normally there is a 5 degrees internal rotation in infants. However, at 8 to 10 years of age, there is an external rotation of 10 degrees present, and which there's no further change beyond that. Also, as discussed, can be a deformity either in the tibia or the hindfoot, which should be differentiated using the heel bisector line. So these are ways to measure the thigh foot axis. So the patient is prone and the angle between the foot and thigh is measured. So by convention, an out-towing is considered positive and in-towing considered negative. Other ways to measure is the patient is made to sit with 90 degrees flexion of the knee, and the angle of the foot with the thigh is measured. Or also the patient can be made to stand with the patella facing forward, and the angle of the foot made with the tibia can also be measured. Next index to be measured is the foot progression angle, which is the angle between the long axis of the foot and the imaginary line of walking. So it is a measure of global alignment of the lip, including deformities and multiple bones and muscular forces acting across each joint. So just like in foot progression, thigh foot angle, in-towing is considered negative and out-towing is considered positive. Normal value is a normal foot progression angle of 10 degrees, and acceptable range is up to 3 degrees internal rotation and 20 degrees external rotation. Normally, it remains positive throughout life. However, there is an increase out-towing seen in young children because of natural increase in external rotation seen at the hips, and also in elderly because of natural loss of power of hip internal rotation with age. So this is a normal foot progression angle, and this is the angle seen with the in-towing and out-towing gait. Another few points to be noted is that the foot progression can be normal even a severely deformed limb. This happens so because deformity in one bone can be compensated with other bone during growth. So in general, the foot progression angle, if there is an increased foot progression angle, the tibia usually twists in direction of the deformity and the femur twists away to compensate for it. So in such cases, gait analysis should be done should be done to localize the deformity whether in the trunk, in the pelvis, or in the hip. So next index to be look for is the foot deformities, which as discussed, using the heel bisector line to look for deformities in the foot. And also normally the outer border of the foot is in a straight line if there is convexity point towards deformities of the foot. And so in-towing usually happens from metatarsus adductus or cavus or clubfoot, and out-towing from pes plano valgus. So moving on to radiographic evaluation of rotational deformities. So as with any conditions, standard investigation first to be done is plain X-rays. Plain X-ray is also to be localized depending on the clinical examination where we are suspecting deformity. So X-ray of pelvis can be taken to rule out any established dysplasias if suspected. And X-ray measure of anterotation can be during the done Epstein view, which is done with the patient 90 degree flexion and 20 degree abduction, and will be good taken focusing on the hip. So the angle made between the shaft and the femoral neck can be used as a measure of femoral anteversion. And with regards to rotation deformity of the lower limb, the tibio-femoral overlap can be taken as a indicator. So increased overlap can be seen out-towing, and decreased overlap can be seen in in-towing. And naturally, a scanogram should be done if any deformity is suspected to rule out other coronary deformities or other limb discrepancies. And just like with foot progression angle, malalignment in the knee can be masked with the coexisting tibial torsion when looked in a improperly taken scanogram. So it should be always emphasized that the scanogram is taken with the patella facing forward. Yeah. So since there are a lot of fallacies with the X-rays, the more reliable method for measuring anteversion used at present is CT, which is a more definitive and more accurate. So measuring the rotational deformity and the limb is done by taking comparing the angles of the bones at various levels. So one is at the femoral neck, second is the distal femur, next between the proximal tibia and the ankle mortise. If there is a increased anteversion which does not correlate to the measurements in the femur or the tibia, then acetabular deformity should also be suspected, and which can also be picked up better with the CT. So how do you measure the femoral anteversion using CT? So the numerous techniques described for measuring anteversion in CT. However, with the same described technique, this is a study published by Case et al. Where they found that even with each technique, there is high intra and intra-observed differences in measuring anteversion. The common distal axis taken in all the studies is a line tangent to both the femoral condyles. So these are some of the techniques described based on the reference point they're taking for measuring the anteversion. Of all the techniques, the most commonly used is the weight lift technique, where this line is taken from the measure of anteversion, the center of the femoral head and the center of the ellipse along the greater trochanter. Other techniques, depending on the levels of the bones they're taking for consideration, there's a Murphy's technique, which is taken the center of the femoral head and the ellipse of the neck. Yoshioka's, which takes the shortest distance of the neck, and Hernandez technique, level of the neck at the shortest distance of the neck. And Jarrett technique is oblique interposition, and the Yoshioka's technique is the oblique interposition of femoral head and the shortest region of the neck. So this is our CT. The anteversion is measured with respect to CT. The angle of the femoral condyles with respect to horizontal is made, and the angle between these two lines between the femoral condyle and the femoral neck is measured. Similarly, tibial torsion is measured using these parameters. So proximal axis, again, there's a lot of variability. The line can be taken either parallel to posterior part of the condyle, tangent to the posterior rim, or the axis bisecting the widest area of the proximal tibia. Again, there are multiple methods described regarding the points to be taken with respect to distal tibial axis. The more commonly used method is the bimallear axis, where the center of both malleola is taken at the tip of the talar dome. Other described methods are Arm's method and the Jenn's method. The Arm's method is the center of ellipse between the median malleus and the incisura. Jenn's method is a circle encompassing the distal tibial articulating surface with the tip of the incisura, where the fibula articulates with the tibia. Again, there's high variability with all the techniques. However, the most commonly preferred and more reliable is the bimallear method for determining tibial torsion. Another point to note is that maximum deformity usually happens in the proximal tibia. So measuring the tibial torsion with respect to the proximal tibial axis becomes tricky, since if even a single cut which is distal to the deformity can lead to mismeasurement of the amount of deformity in the limb. So certain authors, it is recommended to take a cut as close as possible to tibial plateau. However, certain authors recommend the using of femoral condyle as a reference for measuring the tibial torsion. Another new modality which is start to come in practice is the EOS system, which is basically two X-rays coupled to create a 3D software. Main advantage is has slower rotation compared to conventional radiographs or CT. So both parts of scan by both limbs and a spectro system where it renders 3D image. So there are studies depicting the accuracy of measurement using this system, which is comparable to CT. MRI can also be used, only advantage being lesser radiation, but it is more expensive, time consuming, and more importantly, it is less accurate in determining bony landmarks compared to CT. Hence, it is not routinely recommended. The most ideal measure of method for measuring torsion, rotational deformity is 3D CT. So moving on to the indications for surgery. So first one is that there's no definite literature regarding the indication for deformity, torsional deformities in adults. All the literature is pertinent to pediatric deformities. However, what I've seen with most articles, this is a indication followed by most authors. Only symptomatic torsional deformities is failed conservative management with knee, hip or knee or ankle bone, which can be attributable to the deformity, should be considered for surgery. And there is evidence of functional incapacitation because of the torsional deformity, like there's person towing or tripping on fast walking. And also this can also translate as per some authors, an anteversion of greater than 25 degree usually requires surgery, and a thigh foot axis beyond acceptable range of intowing of 15 degrees and external rotation greater than 30 degree after 9 years of age invariably results in surgery. And in post-traumatic condition, acceptable deformity is 10 degrees rotation in femur and 5 degrees in tibia. So just a few points regarding how to decide on the level of osteotomy. So post-traumatic, as you know, is simple. At the direct, we know the level of the deformity and hence can be addressed then and there. However, with respect to congenital and development factors, certain other factors should be considered. So, for example, more important factors should be kept in mind is the affect the muscles and tendon having across the joint following the correction of the deformity. For example, with respect to femoral version, if there is an external femoral, there's a femoral retroversion, then the relation of the quads with respect to the femur should be considered. So in these cases, since there is external femoral version, the quads is in line with the femur, but not with the knee joint. So in such a case, correcting a deformity with the distal osteotomy will further cause malalignment of the patellofemoral joint at the knee. So the entire quadriceps mechanism with the femur should be rotated so that the knee the leg comes into alignment. So in such cases, the proximal femoral osteotomy will be more ideal. And the next factor to be considered with respect to femoral version is the patellar maltracking. As a case where there is an internal femoral excess femoral anteversion and there is evidence of maltracking present. In such a case, distal osteotomy, the proximal osteotomy will actually malalign the quadriceps mechanism more as compared to distal osteotomy. And also distal osteotomy is more pertinent to addressing patellar maltracking as compared to proximal osteotomy. So if internal tibial torsion with the patellar maltracking is present, a distal osteotomy is preferred. If there is no maltracking or there is normal relation of quadriceps to the femur, either of the osteotomy can be done. Similarly, with respect to the tibia, we have to localize whether deformity is either proximal or distal to the tuberosity and whether there is any patellar maltracking. If there is external rotation with maltracking, then it needs both the maltracking as well rotation has to be addressed. Hence, it is done by using an osteotomy proximal to the tibia. Whereas if there is an isolated external rotation without maltracking, the osteotomy can be done just distal to the tuberosity. And if there is internal rotation without maltracking, again can be just addressed as an external rotation without maltracking, can be done distal to the tuberosity. However, if there is external rotation, if there is internal rotation with maltracking, then an external rotation osteotomy at the supratubercular level should not be done. Hence, since it will cause further maltracking, hence other bony procedures should be done. So about the types of osteotomies. So depending on the location, they can be femoral correction can be proximal femoral, diaphyseal, distal femoral. Distal femoral is most commonly done. And similarly, the tibial correction, proximal tibial, diaphyseal, or distal tibia, and combining both in severe deformities, which can be double torsional osteotomies. So the primary advantage of proximal femoral osteotomy, the first distinction to be made with respect to terminology is torsion versus version. So basically, version refers to any deformity and the femur happening proximal to the lesser trochanter, and torsion is implies the diaphyseal deformity happening lower than the lesser tuberosity. So proximal femoral is used osteotomy can be either intertrochanteric or subtrochanteric. With intertrochanteric, more pertinent for addressing version deformities, that is deformities proximal to the lesser trochanter, and subtrochanteric for torsional deformities. Main advantage is that additional deformities in the other plane, like a varus valgus correction, can also be coupled with torsion correction. The most common indication is hip dysplasias and cerebral palsy. However, it is fallen out of practice and not routinely done at present. Implant of choice, previously blade plates are used. Currently, sturdy locking plates can also be used. The most important advantage is that it allows for a high degree of correction as compared to distal femoral osteotomies. And the natural disadvantage is because of the extensive exposure and delayed weight bearing. Moving on to diaphyseal femoral osteotomies, the primary indication is the hip or knee pain, secondary to version abnormality, and the failed conservative management. And there's adequate clinical correlation of symptoms. And again, the most important contraindication is coxa vara valga, which can be addressed better with the intratrochanteric osteotomy. So this is a technique described by Bewley et al. Published in 2018 about diaphyseal, just like a conventional nailing with a GT entry nail, and isthmus is reamed up to additional 0.5 to the nail size. Following the reaming, the stainment pins are placed to control the rotational deformity, and the osteotomy is done using a handheld saw under fluoroscopy. Once the osteotomy is complete, the alignment is so this is a handheld saw. So the saw is passed and the stainment pins are placed in position. So osteotomy is completed and the rotation correction is achieved using stainment pins, following which it is fixed with a nail. Any concomitant pathology present should be addressed. This is a guides use interop to measure the amount of correction which can be guided with the stainment pins. So this is again depicting the procedure. So femur axis anteversion, osteotomy is done, stainment pins are placed. Once it's rotated, fixed with the nail. So the main advantage of diaphyseal osteotomy is just the same as with nailing as compared to plating. So it's less invasive, less muscle stripping, and early weight bearing allowed. And dynamic compression is possible since the nail is used. And more importantly, the proximal femoral anatomy is maintained, which allows easier conversion for total hip if needed in the future. Disadvantage is it's osteotomy of the cortical bone, not the cancellous bone. So as compared to proximal or distal osteotomies, it has higher non-linear rates and abductor damage during nail entry. And theoretically, reaming on unfractured bone also has a significantly higher risk of phantom embolization. So some authors recommend pre-drilling the osteotomy site percutaneously prior to reaming. So moving on to distal femoral osteotomy. So as you know, this osteotomy is more commonly preferred, and it helps to counter the patellar femoral tracking more effectively than proximal osteotomy or diaphyseal osteotomies. But main disadvantage was the use of, the need for delayed weight bearing distal femoral osteotomy. But with current blocking plates, early weight bearing can be initiated, and naturally has better union rates as compared to diaphyseal osteotomies. Generally indicated for patients with patellar femoral symptoms with a high TTDG distance, patellar patellar dislocations, and concurrently MPF deconstruction also be done. Just quickly about the technique, a medial approach is used. Vastus medius relative preserving the MPFL, and the osteotomy site and the plate positions are marked. Again, rotation is controlled with shank spin. So as you can see, the drill marks are made, the shank spin also inserted, and the once the necessary rotation is achieved, can be fixed with the plate. There's another, just like in HTO, biplanar derotation osteotomy is been advocated for same reasons, more stable fixation and to enhance bone healing. In contrast to HTO, the contralateral contact should be completely cut. Again, shank spin should be used. So this is a technique described. So in addition to vertical cut, oblique cut is also made, and the wedge of bone is taken. So as you can see, the shank spin are placed with the desired angle of correction to be achieved. Following the wedge of bone is taken, and the shank spin are brought into position alignment. So this achieves the correction, which is then fixed with the plate. So to sum up, the primary advantage of proximal osteotomy is that a single incision, and more importantly, can be used to correct major deformities and multiple and large deformities. However, needs restricted weight bearing. Diaphyseal osteotomy, while minimally invasive, requires multiple invasive incisions and slower healing. Distal osteotomy has higher risk of neurovascular injuries. Moving on to tibial osteotomies. So proximal tibial osteotomy can be supratubercular, infratubercular. Supratubercular is technically more difficult, and the only indication is lateralized tubercle with the tibial external rotation. Not much. Maximum correction possible is only 15 degrees of correction. So lateral incision is made. Common peroneal nerve is usually released, and fibrillar osteotomy is done to achieve the osteotomy. And moving on to infratubercular osteotomy, usually done in greater than 10 years of age, where there is a patient with a normal cure and there is no normal petafemoral alignment and isolated external tibial torsion. Again, for patients who fail conservative management. Circular X-fix can be used, and also almost always requires a common peroneal nerve release and anti-compartment fasciotomy is done prophylactically. Fibular osteotomy should be done if correction of more than 15 degrees anticipated. So diaphyseal osteotomies is usually for not for very minimal pure axial pain deformities. Techniques similar to standard nailing. However, care should be taken to have accurate entry point, so to avoid varus and valgus malalignment. And also, polar screws can be used to prevent any flexion or procoratum recurrent deformity. Requires prophylactic fasciotomy and CP neurolysis, and early weight bearing can be allowed. Few authors prefer distal tibial supramedullary osteotomies. The primary advantage of it being that there is decreased risk of compartment syndrome, and the distal fibular osteotomy is done proximal to syndesmosis. The distal tibial osteotomy is 4 cm proximal to the joint line. Again, transfer used to control rotation can be used fixed with either X-fix or a plate, and a protector weight bearing up to 3 months is required. For all the techniques with tibial osteotomies, this has the lowest complication rate. So as you can see, the primary disadvantage of proximal osteotomy is a high risk of neurovascular injuries and more technically more challenging. When with respect to diaphyseal osteotomies, just within femur, there is a high potential of non-union. And with distal osteotomy, while the other surgical complications are negated, patient has to be in protective weight, delayed weight bearing for a longer period. So the next entity is the visceral malalignment syndrome, which has been used to describe multiple deformities all throughout. But this is a paper published in 2022 where they went through current literature, and this is the definitive definition of a visceral malalignment syndrome. So it is also known as a tetratorsional malalignment or inwardly pointing knee. So a patient who fulfills all these criteria will fall into criteria of visceral malalignment syndrome. So they should have an inwardly pointing knee on standing. They should have a chronic retropatellar or anterior knee pain, which is refractory to conservative management. And there is either history or a radiographic evidence of patellar dislocation subluxation. And there is a retropatellar instability on examination. And also there is a documented evidence of rotational deformity in the femur and the tibia either through CT or MRI. So based on this, they put up this diagnostic algorithm to decide on management of visceral malalignment. So at each step, we have to make sure it's a diagnosis exclusion. At each step, we have to make sure other differences are considered and excluded. So it's starting with the anterior knee pain and the clinically inward pointing knee. Move on to clinical examination looking for maltracking and apprehension sign. Evaluate the radiography with torsional CT and MRI. If there is a combined torsional deformity of both the tibia and the femur, which has been tried at the trial of conservative management, then should be treated with a double level osteotomy. So just a quick note on double level osteotomy. So in the tibia is done first, followed by the femur, and lateral posterior tibia and medial posterior femur. The maximum correction done in the tibia is usually less than 15 degrees. Again, chance pin is used for the tibia and the femur based on pre-op CT measurements, and sterile angle gauge should be used intraoperative to measure the amount of correction. Plate fix, both the osteotomy are fixed using plate. So this is an case example where you can see there's an increased femoral anteversion with inward pointing of both the knees and external rotation of both the tibia. So the tibia correction is done. So you can see the transpin are placed in the tibia first, following which the osteotomy is done and correction is done, and the transpin are brought back in place, which is then fixed with the plate. Following which, similarly, an angle guide is used to locate to position the transpin with the necessary angle of correction. So after the osteotomy is done, the transpin are brought into alignment to be parallel to each other, following which it's fixed with the plate. So this is another case example which can also be addressed at both diaphyseal levels if the deformity is much lesser. So take home message: clinical rotational deformities can most times be settled, and hence appropriate clinical assessment of the entire lower limb should be done to localize the deformity from either the hip to the foot. Investigations modality wise, the 3D CT scan at present seems to be the most reliable method of diagnosing and measuring, quantifying the rotational deformities. And there are no definitive indications with respect definitive indications, no proven studies, but this is the consensus between most authors. When was only a functional deformity which causes very debilitating for the patient, and anti-version used of greater than 25 degrees, and the thigh foot axis of less than 15 or more than 30. And the decision or level of osteotomy is multifactorial, which entirely depends, primarily depends on the deformity. That is the amount of correction near the deformity and the number of planes of deformity should be addressed, and either position of presence of patellar or femoral maltracking, and also surgeon's expertise. Thank you, sir.
Thank you, Praveen. Elaborate presentation, but we'll have the discussion after all the.
Okay, sir.
Santosh, you're not audible.
So now I'm audible, sir?
Yeah, please go on.
Am I audible, sir, now? Screen is visible, sir?
Yeah, please go on.
Hello, sir? Sir?
Yeah, audible,
Hello?
Please go on.
Today I'm going to discuss regarding the distal femur osteotomy for lateral open with and medial closing with proximal tibial osteotomy in valgus knee. So introduction, the coronal limb malalignment is significantly contribute to the asymmetric joint wears and gait abnormalities and progression of degenerative diseases. Regarding valgus malalignment, it's less common than the varus, but it contributes a variety of conditions, include lateral compartment cartilage defect and arthritis, and lateral femoral patellofemoral instability, and medial collateral laxity. Regarding osteotomy about the knees, around the knee has been done to realign the mechanical axis of the limb to unload the unaffected compartments. And causes for the valgus knees may be osteoarthritis, rheumatoid arthritis, secondary OA, sports injuries, medial meniscus tear, and congenital valgus, and discoid lateral meniscus, and lateral meniscus excisions and all. And now classification for valgus deformity by Krakos et al. Classification, 80% of the cases there will be less than 10 degree of valgus deformity, which can be passively correctable. Those patients will have intact MCL, and 15% of patient will have 10 to 20 degree of valgus osteotomy, not correctable with varus stress. In those cases, the MCL will be elongated but functional. Less than 5 degree of patient, 5% of patient have more than 20 degree of valgus correction, but it's not correctable with varus. And in those cases, MCL will be attenuated, and more lateral soft tissue contraction will be seen in those conditions. And regarding Ranawat et al., he classified into 3 types. The first type will be the minimal coronal plane valgus with minimal soft tissue involvement, and second will be fixed coronal deformity of more than 10 degree with attenuated medial soft tissue involvement, whereas type 3 with more than 20 degree with absent or severe soft tissue attenuated will be seen. And the patient will have previous history of osteotomy has been seen in the class 3. Regarding this classification, this is Sauvé orthopedy. This was a Western France Orthopedic Society who classified for the established in 2020. They established this classification in 2023. There are 4 types in valgus knee of insertion surgical difficulty. Type 1 is completely reducible without any medial laxity or poses no particular problems, or medial approach is but in case the patient if has patellar dislocation, we may need lateral approach for the involvement. And type 2 will be totally or partially irreducible, but without medial laxity, and it's most frequent, and it requires lateral release. And type 3 is reducible, but medial distension laxity and may require management of medial laxity involvement, and it should be repaired. Then type 4 is irreducible with medial distension laxity, so it may include both type 2 and 3. In this slide we can see the normal valgus angle. The normal valgus angle is drawn in the femur with mechanical axis of the femur and the mechanical axis of the anatomical axis of femur. It's normally will be 7 to 9 degree. If the second picture shows the if angle drawn is less than 20 degree, and third will be more than 20 degree. So, if a patient comes to OPD and with valgus knee deformity, things need to be documented and look for you. You should first know the etiology of the valgus knee, whether involvement of the medial compartment or lateral compartment, and which compartment is in it. Then you have to assess it whether it's correctable or it's fixed. And third, you have to know the value of degree of correctability. If it's correctable, know the value of degree correctability. And by giving the valgus stress test, you should know the MCL integrity and the endpoint of the MCL. And you try to measure the thigh grit along with patellar tracking and dislocations. You should document the patellar tracking. And secondly, regarding foot changes like plus valgus and eversion of foot should be known. Other plantar deformities or you should take in consideration hyperextension and flexion deformity, axial or rotational deformity should be taken in consideration in those patients. So coming to distal femur, so indications are moderate correction up to 10 degree for open wedge, large correction from 10 to for closing wedge. So lateral compartment involvement mild to moderate osteoarthritis, we can go for distal femur osteotomy, and lateral cartilage with or without cartilage restoration, and lateral meniscal transplant. Observed contrasting indication of severe medial or tricompartment osteoarthritis and symptomatic medial compartment disease, inflammatory arthritis, and severe osteoporosis. Some of the related contraindication is nicotine use, high body mass index, and individual older than 16 years, 60 years, and severe patellofemoral arthritis. Those patients are in related contradiction. A study done by Brickenman in 2014 for the supracondylar osteotomy around the knee, he said that distal femur is preferred site for the osteotomy for surgical correction of genu valgum deformity. And now coming to this picture depicts that if the McCullis line falls lateral to the medial midpoint, it's called valgus, and if it's fall medial to the midpoint of the it's called midpoint of the knee, it's called varus, and it's measured that mechanical axis deviation in mm. If the mm is more than 15 degree, it is varus. And if the mm is more than 10 degrees, it's valgus laterally. If it's 10 degree. Now when coming to the markings, last time all the angles, that is medial femoral, lateral femoral, distal femoral angle, medial proximal tibial angle, lateral distal tibial angle, those angles. In valgus knee, the lateral distal femoral angle, it will be less than 87 degree plus or minus 3, whereas proximal tibial angle will be more, that is 87 degree plus or minus 3 degree. Now coming to this is the line represent the mechanical axis of the limb drawn from the center of femoral head passing to the center of knee. The A line depicts the B is center of mechanical axis of tibia passing from the center of the knee to the center of the tibia, that is the ankle joint. The C depicts the desired correction angle, and the correction angle is around 6 degree, and the line is drawn in orientation with the lateral opening wedge osteotomy. And this picture shows the pre-op and post-op correction of the patient. The first A depicts the valgus knee, where the mechanical axis fall lateral to the mid joint, midpoint of the knee joint, midpoint of the knee joint. And we have the second picture line. It's the correction angle, the line between the angle between the mechanical axis of femur and mechanical axis of tibia. So after doing correction angle, now you see the line, the mechanical axis of the lower limb falls in the center of the knee joint. And regarding this, the Peko et al., they described the goal. They said that the goal of surgery is to re-correct the neutral alignment such that mechanical axis always falls in the center of the knee. And Martin Quirino, for the distal femur osteotomy for unloading the valgus knee and malalignment, a biomechanical axis, is a cadaveric biomechanical study. In that, he said that for every 10 degree of valgus knee, 15 degree correction results in near normal contact pressure when compared to the area with knee in normal anatomical alignment. So, for lateral open wedge distal femur osteotomy, what needed? Position of the patient, you have to know arthroscopic position of the patient, and we have to do arthroscopic to rule out the any cartilage damage. We have to then incision exposure and osteotomies. You have to pre-op evaluate and do osteotomy, and wedge opening should be calculated. Then plate fixation. There is a small and in this we have to. What are the conditions in pearls in this distal femur lateral distal femur operation is concomitant in settings of concomitant intra-articular procedure can be done with extended lateral patellar approach is recommended. And to minimize the risk of iatrogenic injury, the knee is flexed up to retractor placement when making the osteotomy cut with oscillating saw. And with larger correction, it is helpful to perforate the medial cortex with a drill bit to allow the controlled opening. Then pitfall in lateral distal femur osteotomy is under correction, but not maintaining the maintaining the cortical wedge allograft at the native cortex during placement of non-locking compression screws in opening osteotomy. Then inaccurate trajectory of metaphyseal guide pin should be there, and hinging of medial cortex is too quick. This is a short video of doing distal femur lateral osteotomy. The patient is made supine position with knee flex and lateral skin insertion to the lateral to assess the lateral femoral cortex. In this circumstance, anterior skin incision is followed by formal arthrotomy to involve the lateral femoral concomitant osteotomy at the site. So now the image shows they elevate the periosteum. And sorry, sir. So in this, the lateral cortex is exposed and diaphyseal pins are inserted. Now the marking, they're opening the where the site we have to. The periosteum is elevated. Now where the site of the osteotomy need to be done. Now the osteotomy, the guide pin is passed from medial cortex to lateral to the medial cortex for the correction angle, and we are marking the site with osteotomy. It need to be done. It's marked in the distal in the lateral cortex. Using the oscillating saw, the osteotomy is done, and the angle is elevated. How much degree we have calculated pre-operatively, the angle is elevated, and allograft, the graft, autograft, allograft, which we have to keep in the osteotomy site to maintain the correction. Then we have to assess the mechanical axis of the intraoperatively by keeping a long rod from hip, knee, and ankle. It should pass in the center of the knee end. And after once you confirm the correction is done, then you can stabilize the distal femur with plates and screws. Distal femur locking plates. This is the post-op X-rays. In this, the correction angle of 6 degree has been done and skin closure has been done. So, according to Alexander Grove et al., they said that tomofix distal femur for distal femur, he had done a retrospective study in 22 patients in 23 knees. There is a mean wedge of 9 mm. He said that whose flow is increased and MAD and FAD lateral distal femur angle becomes normal. That is 87 degree and 87 plus or minus 3 degree. And there is a percentage of 100% bone healing. Then by James, High and Cameron, they said the lateral open wedge osteotomy has functional improvement and survival at 5 years of follow-up. He said that they had done a patient with arthritic group and joint preservation group. In the 31 patients of mean follow-up, there is a less accurate correction and pain function score is only 75% and survival. When initially, when compared with 5 years survival rate, it's up to 92%. And this predetermined healing is very good. Advantage of this procedure is that it's a familiar surgical approach and access to the lateral knee for concomitant procedure is easier and fine-tuning intraoperative correction can be done in this procedure. So what are the risk factors? Are hardware irritation, malunion, non-union, because we are keeping an allograft or autograft, what is made chance of malunion, non-union. And if you do correction intraoperatively without a problem, it may go for overcorrection or mal correction. And if the hinge is not proper, patient may lead to patient will they will go for a iatrogenic fracture and patient and neurogenic complication. Now coming to techniques of medial closing wedge proximal tibial osteotomy in valgus knee. So it helps in advanced cartilage restoration and mechanical meniscal transplant procedure for preservation joint. And when compared to distal femur osteotomy, the medial closing wedge osteotomy alters the joint contact force in both flexion and extension. So indication is that valgus alignment up to 10 degree and involvement of lateral compartment osteoarthritis and previous surgical procedure like lateral meniscectomy, lateral meniscal repair and chondroplasty of surgical procedure in the lateral compartment. So an adjuvant procedure in patient who undergo concomitant meniscal allograft transplant or lateral compartment cartilage repair procedures. So in the condition with the patient with or medial compartment disease and inflammatory conditions and nicotine use and relative contraindication is obesity with BMI more than 35 and age greater than 60 years and severe to moderate patellofemoral arthritis. And coming to the pre-op of this patient, the X-ray shows the full-length AP and lateral radiography of the lower limb, and we are calculating on the left side, left lower limb, the medial distal femoral angle and proximal tibial angle, and B shows the hip knee ankle angle with a plan of 4 degree of correction to the tibial spine. And this image shows that AP of the pre-op templating for medial closing wedge proximal tibial osteotomy. That is 4 degree of correction was calculated using HAK ratio, HAK angle, and it is transposed on the proximal tibia to the point 2 centimeter below the lateral tibial surface, joint surface. This wedge of the bone to be removed in measurement of the left medial cortex. In this case, it is measured about 5.7 mm. So this is the intraoperative X-ray of wedge correction. The white arrow mark shows that the cut should be below this KOS. The wedge should be in the measure in the wedge, and we have to measure intraoperatively. The hip, the long rod should be placed from the hip to ankle, and it should pass in the center of femoral head, center of the knee, and then center of ankle. So this is the X-ray of post-operative X-ray of tibia, where the pre-operative 90 degree was corrected to 86 degree. This is a full scanogram of the post-op patient. So in this pearls are the elevated upper elevating the upper border of pes tendon into for the posterior assessment, posterior assess, and the lateral point of osteotomy should be at the proximal tibio fibula joint in order to avoid the impingement of fibula when your closing osteotomy is done. And to avoid iatrogenic fracture, you always ensure 5 mm of lateral hinge should be there, and you should do a arthroscopy and fluoroscopy before doing know the lateral compartment. There is wear and tear, osteoarthritis, cartilage damage should be documented. In this procedure, can always resect additional bone if needed. The pitfall is incision should be small in order to avoid the further arthroplasty incision. It should not avoid, and ensure fluoroscopy view hip, knee, and ankle before draping. And there is to assess the postomedial tibia, position the lateral thigh post high to allow we can patient can be knee can be flexed to figure of 4 position. When elevating the postomedial soft tissue from the proximal tibia, you should be careful with medial genicular artery may get injured, and assess the intraoperatively with fluoroscope while correcting or closing the osteotomy. Close the osteotomy very slowly in order to prevent the iatrogenic fracture of the hinge. This is small video. This is a diagnostic done in the patient with before the scopy before correction. It shows the lateral compartment has been fully damaged, and this is and the cartilage and is damaged. The incision should be made. The patient is knee is flexed and incision made. So now coming direct up, the periosteum is elevated from the proximal tibia, and the superficial MCL is being split. Now their marking is for the sorry. Direct approach of the proximal tibia, medial approach to proximal tibia. Then sartorius fascia is split under the upper border, and place under is identified and elevated from the tibia and is tied. Then superficial periosteum, superficial MCL is split and is from the portion 1/3 of the proximal tibia and is infused. Now their marking is done for the tibial correction for closing, and this is the biplanar. The marking is for the biplanar. Intraoperative, the guide wire is from the medial to the lateral cortex for the hinge. The osteotomy site is marked. Now the measuring how much mm of to be corrected intraoperatively for the closing. The wedge is now taken from the proximal tibia, and the since it's the involvement is the closing wedge, the biplanar, the medial compartment of the that is been done for the biplanar. And using oscillating scar, the wedge is now taken off. Since the hinge is there, slowly close the with mild varus and correct the osteotomy and check for the alignment intraoperatively. The pes has to be close above the plate, and the suture should be inside below the plate. That is the post-op X-ray. So, medial closing wedge osteotomy for valgus knee deformity, a clinical by clinical results for 4.5 years follow-up in 113 patients. It says that it's less common, and it's a retrospective study where survival rate is over 80%. and post-op laxity of the knee is seen in 26% of patient. So a study done by Robert et al. He compared the medial closing wedge proximal tibial osteotomy and lateral open distal femur osteotomy. His advantage in this is there is no medial closing, there is no need for bone grafting, and there is a bone-to-bone healing is good, and we can make the patient early weight bearing. But lateral open wedge osteotomy, it's familiar approach, and in intraoperative you can do fine correction, and you can assess for a concomitant procedure can be done. The disadvantage of the medial closing wedge osteotomy is that there is excess if there is excessive joint and obliquity of more than 10 degree will be done if you don't know proper, and fine tuning correction cannot be done in the medial closing wedge osteotomy. Whereas lateral disadvantage is that minimally effect on the joint, contact inflection, and there will be a hardware irritation. So take home message. Most common in valgus knee, the correction will be distal femur is common, and there is no specific osteotomy is best, and different implants has been used in choice. Bone grafting depends on the size of the wedge in the open, and outcomes are good both in medial closing wedge, distal femur, lateral distal femur opening osteotomy. Thank you, sir.
Thank you, Santosh. Am I audible?
Yes, sir.
Just as you mentioned in the summary, valgus correction mostly would be required in the femoral side. So distal femoral osteotomy is the common thing which is required. So closing is better than opening because you need a bone graft for opening if you have a gross opening. Healing is better with closing wedge osteotomy. But technically, closing wedge osteotomy is slightly difficult because you need perfect calculations. Unlike an open wedge where you can fine tune and adjust the opening, closing wedge you cannot fine tuning. So your calculations must be correct, and your osteotomy must be technically correct to do a closing wedge osteotomy. So that's the if you're not confident, you can go for an open wedge and put a graft, which is always okay in a metaphyseal bone, cancellous bone. Regarding valgus correction, usually it won't be there in the proximal tibia. But because you're used to seeing proximal tibia, medial opening wedge, medial closing wedge again will be easy in the valgus correction. But you need to check the cora and measurements and correct the deformity at the site of deformity. Regarding valgus corrections, I not much to add in valgus. Going on to the rotational corrections, rotational deformities. Usually, most of the rotational deformity corrections which we've done is in concomitance with other osteotomies. Usually, it's going to be a valgus osteotomy correction. We would have done a combined rotation corrections. But for picking up rotational deformities, it's very, very difficult. Gait might be altered, but most of the patients would adopt to those rotational corrections, and you might not be able to pick up unless you look for it. As Praveen had showed, you need to clinically look for those deformities. Even clinically, it is difficult. Only if you suspect clinically, look for it, then you will be going on and doing a CT to confirm whether there is rotational deformity. So the best way to look for these rotational deformities is to put the patient prone. Unless if you put the patient prone, you will not be able to pick up these rotational deformities. So in suspicious cases, especially in patellar instabilities or patients who are complaining of in-toeing gait or gait disturbance, to put them prone and check. In adult population, it might not be very common, but in pediatric adolescents, it's much more common. And the other rotational deformity, pure rotational deformities may be required in an adolescent or pediatric population rather than an adult population. So you might not come across these patients frequently, but when you come across them, you must know how to assess them, evaluate them, and how to manage them. And rotational corrections, nothing much to add. There is a method where you can do a step cut osteotomies. So it's like HQ step cut, where you have more stability on the rotation and you can assess the rotation more accurately. And valgus correction, Praveen showed that biplanar distal femoral osteotomy for rotation. You can add a valgus also. When you take a wedge in the other plane, you can add a valgus correction also. So that's one additional point which I want to add. Regarding rotation deformity, not much, but assessing these patients are very, very important. And during growing age, there is always a chance they can get corrected. And when you plan for these, do not try to correct rotation deformities at 2 levels and in one level at one go, because that will again become a problem as the joint goes into external rotation and internal rotation. Yeah, most of them adapt to the rotation deformity without much of a problem. You would have seen a lot of tibia fractures being fixed in internal rotation, external rotation, about 10 to 15 degrees. Usually they accept it because of the hip external rotation and internal rotation. They would complain for a few months or years, then, but unless it's grossly rotated, they adapt to the rotation deformity. And again, a rotation deformity, when it's childhood or it's congenital, all the muscles would have adapted to that kind of rotation. So when correcting the rotation, you should not overcorrect. Where the muscles, suppose it's in the hip, the posterior rotators and anterior rotators would have adapted and have been tight. So getting it back would be difficult. So in a growing age, it's okay. When you're correcting a congenital deformity at an adult age group, again, you have to be wary of the muscle tightness which is in there chronically with these patients. So those are the extra points I would like to add. And regarding any other doubts in the rotation, valgus and rotation osteotomy? Any points you can ask? Regarding MPFL, Chetan covered most of the other techniques. What you can learn is there are so many different techniques for MPFL. Most of the techniques are actually successful, and even though so many newer techniques are there, age-old technique of Rue and Goldwhite also is successful. The thing we are moving forward is minimizing the incision, reducing the implant cost. Contrarily, some companies increase the implant cost. Mainly, it will become more non-invasive and minimal incision. Avoiding implants has been few techniques with that basket weave, the sleeve, periosteal sleeve, which Chetan mentioned. But in the femoral side, usually we would require an implant. Things which are not covered is in open physis. Any inputs on open physis? What? Open physis.
One is which I mentioned. One is which I mentioned, the kids zone, just distal to the physis, above the lumens at time, directing distally and anteriorly, taking care that we are not in the trochleum. Other articles which I found was using the anchors without actually.
Anchors, this screws, or just an adductor sleeve where you just tie it around the adductor magnus tendon. All that has been going to be successful in the pediatric case. But the only point which is the point is distal to physis. Recently, when we last 2 weeks back, there was a IAS presentation, an author from Bhopal, I think. He presented a case series, but we mentioned all of these are proximal to the physis. Actually, distal to the physis. Recently, Keithan also had a discussion on the controversy. He had fixed it proximal to the physis. But when you see the X-ray, it appears as though it is proximal to the physis. But when you see the MRI, medial physis actually goes up in that posterior part. So it is this point is distal to physis. So you should not make a mistake of going proximal to the physis. You have to come facing downwards. Suture anchors are good options, but tensioning the tendon, fixing the tendon over there will be a problem. You need a socket for the tendon to get fixed. But in a pediatric age group, even soft tissue will be okay. All suture anchors are also probably one time not used. What we've tried is tenodesis screws, which is blind screw. But pediatric age group, the fancy screws too soft, again, that'll be a problem. So you need to have a few backups for this pediatric age group. An adductor sling is an alternative where you don't have anything, you can just tie to the adductor sling. Good tension is the problem in the pediatric. But the main thing which you, if indicated, it's better to do in the pediatric age group because when they grow, there is chance of remodeling of the trochlea. So when you do it in the growing age, fully flat trochlea, the chance of becoming a shallow trochlea. Because trochleoplasty cannot be done. And trochleoplasty is a normal procedure. It's usually indicated only as a secondary procedure in failures. So any more points to access 834? If no other doubts, nothing more, shall we end the meeting?
Yeah, please. Good meeting. Thank you.
Good meeting. Thank you.
Good
Have a
night.
good day.
Good night.
Right. Thank you, Gopal. Good night.
Santosh, congratulations on the new baby.
Thank you. How are you, sir?
I'm doing fine. It looks good. I'm seeing the conference room. Wonderful.
So I'm slowly trying to get back to our old routines to meet in person.
Yeah. Right. I'll say good night.
Right.
Okay.